I thought we might make a start. Two of the speakers are still coming in from Adelaide, but they should be here shortly. So welcome to the second event for Hats Off for Health Chats, with the first one being in Melrose in March. I think I said this to the men in Melrose, but I'm actually relieved that I've got a bit of a crowd here. I think for the whole week, when I spoke to Simon last Saturday, and then for the whole week, I think I had about 10 RSVPs, and half of those are my family members, so it was going to be quite an intimate affair, but it's nice to see that so many of you have come out. So I really do think that you'll get a lot out of the talks tonight. I can vouch for 3 of them. I don't know about mine, but the other talks will be really informative. And if anything, it's a good night out to catch up with a few friends, have a few drinks and some food. I think I know most of you in the crowd, but for those that you don't know me, my name is Alice, Alice Bennett. I'm a gastroenterologist based up here in the mid-north. I work part-time at Christa Brook and Pirrie, but I'm also a local. So I grew up at the bottom of the Hogshead with Henry and Will and Mum and Dad, and then I came back and have married a farmer, Matt, at Bullaroo. So we have 3 boys there. I'm really passionate about rural health. Obviously, I'm a rural person myself. I've got a young family with Matt, and I feel very passionate that we should have the same healthcare as what our metropolitan counterparts have, and I think we do. We have some fantastic GPs, Simon, and many GPs around the area, and so we're very lucky. Obviously, distance plays a bit of a barrier in some aspects of our healthcare, but I don't think it should have any impact on health information provision. So a couple of years ago, while I was working with my patients, I often like to give handouts, information handouts, whether it's on reflux or bowel polyps or bowel cancer, and I was finding that there was a couple of topics that didn't have the information that I wanted to give out, like appropriate handouts. So I started a website or a blog page where I used to put up some occasional articles about topics that I thought were good to know bits more information about, some things that we don't like to talk about often, and it was quite well received. And I am biased because I think everyone should know gut health is probably the most important part of your health. It's the most important organ in the body. But obviously there are other topics and other areas in the body that I think are very important that we should know more about. And then that's what sort of gave me the idea of whether we should put on these health information nights, and whether I could convince some of my colleagues to come and give some expert advice about certain topics that people might want to know a little bit more. So we had our first event in March for a separate men's and women's night. And I think it was about 30 or 40 men and over 100 women on those nights, and the feedback was really good, that people really enjoyed it and got a lot out of it, and sort of suggested a few other topics that we could do if they were going to go again. I'm not sure whether it's controversial setting up separate men's and women's nights. I think it's very important. Obviously, not all health topics are equal in terms of gender. There's obviously some that affect men and some that affect women, and obviously things that are the same. But also talking about it as well. I think sometimes it's easier to talk about certain symptoms or certain topics if you're amongst men or amongst women. So that was the idea. But I don't want to be political or controversial in this day and age. So this leads us to our second event. So we have the men obviously tonight, and the women tomorrow night, and we've got 4 speakers tonight and 5 tomorrow. Before I start, I just want to make some thank yous. First of all, to the Orroroo Football and Netball Club for allowing me to have this event here tonight. Particularly Sam and also Adele have been so good to work with, so easy to work with and supportive of putting on the show, and I wouldn't have been able to do it without them. Poor Adele, she's my sister-in-law, and I think she got, drew the straw of me asking her a lot of questions and things, and was able to help me along with Henry this afternoon, and my mum for setting up. Also to Meredy for videoing it. She videoed in March and again tonight, so they'll be uploaded to the website. So if you wanted to watch the topics again, or if you had any friends or family members that wanted to have a look, then they'll be free for everyone to see. I was also lucky to get an AgriFutures Rural Women's Acceleration Grant for this project. Unfortunately, the money can't go into the actual running of the project, which I wasn't aware of. And so I'm still looking for funding to do more of these down the track. So So what we'll do is, most talks will go for about 20 minutes. We'll probably have 5 or 10 minutes in between questions at the end, but it'll give a chance if you need to go to the toilet or get another drink in between those. So I'm going to lead off tonight. As I mentioned before, I'm very passionate about rural health. I'm also passionate about gut health, and hence why I've become a gastroenterologist. I think we do tend to talk about some topics more at ease than others, obviously. You know, if someone's pulled their hamstring or, had pneumonia or another ailment, we quite often feel at ease talking about that with each other at the football or, with other family members or with friends. But bowel health and gut health is probably not a sexy topic to talk about, and often, people, it is for some quite embarrassing to talk about. And that's where I wanted this topic tonight to be able to share some information and really try and emphasise the importance that we should be talking about it more, if not with our family members or our friends. If we find that there is something abnormal or that we're worried about, to have the confidence to go and seek out help from our GPs or other medical staff to see, whether it's something that's simple that can be fixed or whether it is something a little bit more complex that needs some further investigation. But definitely bowel health and bowels are something that we get a little bit nervous talking about. And even though I'm a medical practitioner, I know that after having babies, we talked about poo a lot more than we did beforehand. So from no talk at all to wondering when they've pooped, how long they've pooped, how many they've had, what colour it is it a poonami, and it just goes on. And we're quite okay talking about our children's bowel health, but we still get a bit nervous talking about our own, or not nervous, but we just don't do it as often, and really recognising what's normal with your own bowels, and then being able to identify if there's anything different and being able to talk about it or not ignoring it, I think is the most important thing. And the main idea is then, if there is something abnormal, to pick it up early, because if it is something sinister, hopefully we can cure it or treat it quite quickly. So bowel cancer, what is bowel cancer? Well, I think we have to go back to basics. What's our bowel, and where does this bowel cancer happen? So we've got our large bowel connected to our small bowel. So our large intestine starts with the rectum at the bottom, with our colon, and then links up to our small bowel and then our stomach. And bowel cancer predominantly occurs in the large intestine, so anywhere in the colon or the rectum, and that's why you may hear of the colorectal cancer, colon cancer, or rectal cancer. Colon cancer or colorectal cancer is prevalent in the Western world and very prevalent in Australia. We have one of the leading rates of bowel cancer, and the incidence is increasing. And one of the latest statistics shows that we've probably got over 15,000 cases that are diagnosed each year. And while we think that bowel cancer sometimes is a diagnosis of the elderly or older people, it is occurring in the young, and there's about 10% are being diagnosed young onset, so less than the age of 40. The youngest that I've diagnosed is 24, but there have been a few people, that is extremely young, but there's quite a few people in the late 40s or early 50s, so it's not necessarily a disease of the elderly. Concerningly, of those 15,000 that are diagnosed, at least 5,500, or just under 5,500 are dying from bowel cancer each year. Now, the incidence of young onset is increasing, and we're not really sure why. We think that it possibly is due to our lifestyle, and I'll talk a little bit more about that later. But there's a lot more research that's going in to work out whether there is some sort of genetics behind this. And if we think about in terms of our lifetime risk, sorry I keep walking in front, but there's probably about a 1 in 15 chance that we may develop or have already developed bowel cancer. So possibly 1 or 2 of us may develop it in the future. So what is bowel cancer and how does it develop? So normally in the large intestine and in the small intestine, there's a really nice balance or regulation between new cells that grow and develop, and that the older cells then die off and that shed out in our faeces. And there's a really nice balance of those that come in equal those that go out. But if some of these cells in the lining of the bowel develop a mutation in their DNA, and this might be something that's inherited, or something that develops due to our environment, then sometimes these cells gain an advantage of living in our bowel. And that advantage might be that they just don't die off, or they might be accelerated in their growth. So it's okay if it's 1 or 2 cells, but if there's more cells that develop this change, then we get this abnormal sort of cell pack of these cells that eventually develop into a clump, or what we call in the bowel a polyp. Now, these polyps, when they develop, are very small, and majority of them won't do anything, may grow slightly. But if they do develop more of these mutations in their cells, and that might be, again, through environmental things like smoking or poor diet or what have you, they can get more of an advantage of being in the bowel, so they might have more of an accelerated growth, or they may be able to form their own blood supply. They can get bigger and bigger, and eventually some of those polyps can develop into cancer. Not all. We think maybe 1 in 20 of these polyps can develop into cancer, but we don't really know which ones they are when they're at such a small stage. So if we ever see any, we take them off. Polyps are common, so probably about 20 to 40% of people will develop some bowel polyps at some stage in their life, and they're more common in male and as we get older. Look away now if you're a bit squeamy, because I've got a couple of photos of what a very large polyps can look like in the bowel. So these were some of my patients over the last 10 years, and these polyps are at least 3 or 4 centimetres in size, and would have no doubt led to bowel cancer if they were left there. So some polyps are quite flat in the bowel, and some look like a bit like a mushroom, and it can be on a stalk. So these were taken off, and they were just simple polyps, but that could have been a lot worse. So who gets bowel cancer? As I said before, it's predominantly, we've thought of it as a disease of the elderly, but it can occur at any stage, and it is occurring more in the young. Men and women are affected, probably a little bit more male-dominated, possibly we think due to our lifestyle. Maybe men are drinking more alcohol, or their diet might not be as healthy as what it should be. Family history obviously plays a big role. So 30% of patients that have bowel cancer do have a family history of bowel cancer, but that means 70% of cases don't have a family history. And I think sometimes we think that we might be safe if we don't have a family history, and that won't happen to them. But 70% of cases don't have that genetic line. And with age, it does sharply increase after the age of 50. I think one of the best statistics that we have is that if bowel cancers are picked up early, 99% of them are cured. The trouble is, fewer than 50% are detected early, which is a terrible statistic, and one that we are trying to change, and that's mainly through our screening program, the National Bowel Cancer Screening Program, which I'll talk a little bit about later. But if cancer is picked up early in this scenario, the majority are curable. Okay, so I think this is one of my most important slides. What are the symptoms of bowel cancer? People that have a bowel cancer at an early stage often don't have any symptoms, which is really concerning and worrying, and that's where our screening programs are really important. So after the age of 50, our National Bowel Cancer Screening Program sends out a stool test to check for any blood in the bowel, because we know that these polyps and bowel cancers can bleed. But people have got to do the test. We can't just leave it sitting in our cupboards or in our drawers. You've actually got to do it, and so that's the only way generally to pick up a bowel cancer without any symptoms. There is another couple of things I'll point out below. But other symptoms, when people do develop symptoms, what can they be? Well, any bleeding in the bowel can possibly be a symptom of bowel cancer. Any blood in the bowel is abnormal, regardless of what it's from. It could be something quite simple. It could be something like hemorrhoids, which can be easily treated, but it's abnormal to have it in there. It can be bright red, it can be dark red, it can even be black in colour, old blood. But any sign of blood in the bowel motion is abnormal, and we should work out where it's coming from. If it is hemorrhoids, then that's fine, we can treat that. But if it's not, if it's something else, we need to know what it is, and can we treat it, and is it bowel cancer. You need to know what your bowel habit's like, because we need to know if there's been a change from being your normal pattern, and if it's a persistent change, then that should also be investigated. So if you're a once a day person that then suddenly starts to go twice a day and then 3 times a day, and it lasts for quite a few weeks, that's a change. That should be something that we should further investigate. If you're a once a week person and you've been like that for 20 years, and suddenly you know, it's once a fortnight, or the other way, if it's once a day, then that's a change for you. Everyone's different. You need to know what your bowel habit's like, and then you can work out if something has changed and if it's abnormal. Other symptoms, so and with bowel cancer, it's not necessarily constipation. It could be diarrhoea. It could be a sensation that you're just not feeling like you're emptying properly. Anything that's not feeling quite right is a change for you. It could be a change in the shape or the appearance of your stool. It also could be abdominal pain and swelling. And if you think about a lot of these symptoms, they could be explained by something very simple, like hemorrhoids, or it could be simply bloating that's causing the pain. And you know, if it's abnormal for you, you should go and speak to your GP, because it could be fixed quite easily. And if it's not fixed, then we can work out what investigations you need to find out what's going on. A pain or a lump in the anus or the rectum can be a sign. And also other things not necessarily related to your bowel specifically, but if your GP finds that you're low in blood count, you're anemic, particularly if you're low in iron levels, that possibly could be a sign. If you're tired or weak, I think I've been tired for 8 years now, but new tiredness might be a sign, weakness and unexplained weight loss. So not if you've changed your diet and started a new exercise regime. If you're losing weight without any obvious reason, then it could be a sign. So all of these things I want people to be more comfortable of recognising initially, but also talking about. And it might not be talking about it with your friend, but at least having the confidence then go to your GP and have a chat, and to see, you know, whether things do need to be further investigated. When we think about what increases your risk for bowel cancer, we can split that up into 2 categories. So the modifiable risks and the non-modifiable ones, the ones that you're stuck with. So the modifiable ones, we know that smoking increases your risk of bowel cancer. There's probably about 70 chemicals or carcinogenic chemicals that have been linked to cancer, and a number of cancers, not just bowel cancer. I think I did read a statistic where people that smoke 40 cigarettes a day increases their chance of bowel cancer by about 40%. So stopping or at least cutting down can improve that. Alcohol, we have our safe alcohol guidelines, but really any standard drink or any drink of alcohol increases your risk of bowel cancer or any type of cancer. It's all relative, so you know, I'm not saying you can't have one drink, especially when we've got the bar open at the back, and I think the other processed meats are on a few of the platters. It's all relative, but there is no safe drinking or safe guidelines when it comes to alcohol and bowel cancer and other cancers. Being overweight also increases your chances, particularly the central weight distribution in that region. And excess processed meats, particularly red meat, is a risk factor that increases the chance of bowel cancer. When we think about the non-modifiable ones, we've already sort of touched on those. So age, obviously we do want to all get older. That's a great thing to have a birthday each year, but it does increase your risk, particularly after the age of 50. Family history, so family history is different for everyone, and it depends on who's affected in your family. So there may be some specific gene that is known in your family that puts you at really high risk of bowel cancer, and so then screening and trying to pick up cancers early may start a lot earlier. Or you may have a family member, one family member or 2 family members that are infected. And you know, a distant cousin with bowel cancer is very different than your brother that's had bowel cancer less than the age of 50. So we do have, Simon and I have these tables working out what your risk is of bowel cancer and when you could potentially need screening early despite having any symptoms. And the hereditary conditions we've just spoken about. Yeah, I'll skip that one. So how is it diagnosed? So I suppose diagnosis of bowel cancer falls in two categories. So one category is that you might be at increased risk of bowel cancer if you have a family member that's affected, and that you might already know that you need screening, so you would go sort of straight to a colonoscopy, or if you're in the bracket that you have had this national bowel cancer screening check that checks for blood in the stool, and if blood comes back in that test, then the next step would be to find out where that bleeding's coming from. It doesn't, not necessarily always bowel cancer, but we need to have a look in the bowel with the colonoscopy. And then the other group is that if you do have symptoms, then you might go down that path. So if you do have symptoms, speaking to your GP, they would take a thorough history and do an examination of you, feeling the abdomen. Sometimes they might feel in the rectum, just to see particularly if that is an area where more symptoms sound like they're coming from. Blood tests would be possibly the next thing, looking if you're anemic, what your iron levels are, maybe checking your kidney function and liver function. Sometimes they might organise some imaging, so an X-ray or a CT scan, but usually if they are concerned that it sounds possibly like bowel cancer, then they would refer to myself or a surgeon for consideration of a colonoscopy. Sometimes they also might do a stool test to check for any blood, any infection or any inflammation as well. And if it looks like it is an infection that's causing the diarrhoea, then they obviously would treat for that. But if the symptoms are still there and ongoing, then that might be another avenue to come back. But yes, it's a colonoscopy. It's the only way that we can diagnose a bowel cancer. No one likes a colonoscopy. No one likes coming to see me for a colonoscopy. A bit like pap smears with women. No one likes having them, but compared to the alternative, if we don't do a colonoscopy and we don't diagnose a bowel cancer, and then it progresses and becomes sort of a later stage diagnosis, we've sort of missed our chance. Last time in Melrose, I brought along a colonoscopy, a colonoscope to show everyone, and I got a few people a bit worried, I think, but I forgot to get it this week, so I'm sorry. Just to show you what it's like. So the worst, some of you may have had colonoscopies, but most people agree that the worst part about it is the day before when you're at home, where we need to give you a bowel preparation to flush you out and to have everything clean. So you do that in your own home. It's not nice, it tastes terrible, and I don't know why we can't advance our technology to make something more palatable. I'm ashamed of how bad it is, but that is the worst part. You're in your own home, and when you come into the hospital, it's under an anaesthetic. You don't feel any pain, you don't feel anything, you're covered up, and once you're asleep, then we start the procedure. And it's looking all the way around the large bowel, seeing if we can find out either what's causing that little bit of blood in your stool sample, or what's causing your diarrhoea, or whatever symptom that you've come along with. If we find any little polyps, these growths, we can usually cut them out, and you can't feel that. Often they are only millimetres in size. Sometimes they are bigger. And if we find a bowel cancer, then we can take some samples away to send them away to be analysed and to diagnose that cancer. It usually takes about 20 minutes. You wake up out in recovery. Hopefully, majority of people are pain-free, and we usually give you sit down and talk to you about what we've found or what we haven't found, and you can go home that day. I think the biggest thing I find with farmers is making sure they don't drive for the next 24 hours. But they say they don't. I don't know whether that's true or not. Diagnosed, obviously, we need to be thinking about what type of treatment. And the majority of people do need surgery. If we have caught the bowel cancer early, usually the surgery is cutting out that lesion and rejoining straight away. I think one of the biggest fears of people have is having a bag, and some people do need that, but the majority of people don't. And then depending on how advanced the surgery is whether or not you need additional treatment, and so that can come in the form of a number of different things these days, not traditionally chemotherapy and radiotherapy, but we do have a lot of other treatments. How do we reduce our risk of bowel cancer? And I think one of the most important things is leading a healthy lifestyle and recognising what our normal bowel pattern is for us. Everyone is different, and no two people are generally the same. So recognising what your normal pattern is, and then also recognising when something has changed and when then to seek help. I think that's one of the most important things. The other thing, though, is our national bowel cancer screening test. So at the moment, our government has provided funding to give out a screening test for everyone over the age of 50 in the male, and to do that every 2 years until the age of 74. There is evidence from America that perhaps we should actually be doing it from the age of 45. So that's what some of us have been recommending, and you can get tests from your GP, from the chemist, from Rotary, a lot of different avenues. And that looks for any blood in the bowel, okay? And blood that you would never see, okay? A drop of blood a day, which you would never see in your stool, in your faeces, can be picked up on this test. And if there is that blood in the test, then you would be sent off to have a colonoscopy. So it does, evidence over the last few years with these National Bowel Cancer program, it does reduce the amount of bowel cancers that are detected. So it works, it's picking up polyps early, and the number of people that have had a positive test and for the first time and have had a colonoscopy and we've taken off these very large polyps, it's so, you know, it's an amazing feeling to know that if they didn't do the test, they would have ended up developing cancer, and they've saved themselves that. So that's fantastic. But we've just got to do the test. So only just over 50% of people are doing the tests. So we're really trying to get that awareness out there that they are so important. They're not 100%, but the more that you do, that sensitivity or the statistics increases or improves. So that is really important. And then leading a healthy lifestyle and avoiding those modifiable risks, so making sure that, you know, you reduce your alcohol, you reduce or stop your smoking, regular exercise and good weight control, and a healthy diet. So plenty of fresh fruit and vegetables and minimal processed meats, other than tonight, but all in moderation. So as I said, I'm really passionate about gut health, and I know Sam is, so I've got an ally tonight. But if I can tell one, you know, impress upon you one thing is to learn what your bowel habits, your normal bowel habits are, and if there is a change, have the confidence then to seek out some help, and it might be something really simple that can be fixed. And if not, it might be something that needs a little bit more investigation, but don't ignore it, because, you know, wouldn't we feel so sad and so silly that if in 5 years' time it does get worse, and in fact it was something that we could have picked up a lot earlier and cured by, you know, just seeking out some advice and some investigations. So I'm not sure whether anyone's got any questions at all about bowel cancer. I thought that was a funny one. Talking about bowels is not fun for a majority of people. I've got 3 boys. The amount, and Matt knows the amount of butt jokes and poo jokes and things, and mix that with me with being a gastroenterologist. It's a great household at the moment. So, yeah. All right, we'll take a 5-minute break and then we'll get on with the next speaker. Tonight. So I've got the pleasure of introducing Dr. Simon Jackson. I don't really think I need to introduce him because he's a well-renowned GP here and in Jamestown. I've had the pleasure of probably working with Simon since I've been up here. I think we probably started very similar times, around about 10 years ago, so the years go very quickly. I think I get nervous when Simon sends me a patient because I know they've been very thoroughly worked over, and if he doesn't know what's going on, then I'm like, oh, I really need to think about this. So I'm going to cheat a little bit with introducing Simon. He sent me a bio. Well, I actually don't think he sent me a bio. I think I had to look for his biography. So Simon graduated from the University of Adelaide in 2010 and completed more training at the Royal Adelaide Hospital, Women's and Children's Hospital in the Lyell McEwen. He's a fellow of the Royal Australian College of General Practitioners and has been working at Goyder's Medical since 2014. So yeah, exactly the same year as I started. He's completed further obstetric training, paediatric training, and also sports medicine training. So please give Simon a warm welcome. He's going to be talking about concussion tonight.
Thanks very much, Alice, and thanks very much for organising these nights. They're great to be able to impart a little bit of health knowledge and information, and also as a social catch-up. So yeah, most of you know me. I'm Simon, one of the GPs here. I'm no expert in concussion, maybe more of an expert than the Port Adelaide team doctor, but we'll wait and see. I'm interested in sports medicine because I used to play football. You know, my only premiership was the 1999 under 14s. There I am receiving my medal, and I suppose my most best moment playing local footy here was when I almost won a hit out against Aidan Lee playing up in Peterborough. The only way I got close was putting him in a headlock, which Andrea was not happy when that was in the paper. So I'm going to be talking about concussion, which is quite topical, and we're getting more information about it as we go. So concussion isn't a new thing, it's been around for a very long time, and at least concussion in sport, the first recorded information I could find was in 1914 in America, when looking at American footballers, and they sort of said they'd turn a bit funny after thought they'd just been training too hard. So it was initially put down to overtraining, and later found out that maybe repetitive head knocks might have led to them having this funny behaviour. But we're getting more and more information about concussion, and just this year there was a release of further information which sort of then refines our guidelines a bit more about what we know about concussion, how we manage it. So there's an international conference on concussion which was held end of last year, and just a few weeks ago, June this year, they released some refined guidelines, which it seems like it hasn't quite made it to the AFL. In the news recently, they were talking about a SCAT-5 test, which now we've moved on to SCAT-6 tests, but maybe that's why they couldn't diagnose Lear with concussion last weekend. So what is concussion? Well, we don't really know exactly what causes it, but it's a rapid onset of symptoms, usually from a head knock, but it can occur from other means. And it's really a vague lot of symptoms. It can be headache, difficulty concentrating, just don't quite seem to be their normal self, any sort of changes in emotion, loss of consciousness. And probably one of the most common ones is not quite feeling right, which I'll go on and show you in a sec. And please, if you've got a question or something in between, just interrupt or put your hand up. So concussion can occur from a direct blow to the head, can occur from a sudden change in direction with the brain rotating. It can also occur when someone comes to a sudden stop and the brain bounces back and forwards off the skull. And really concussion is like a bruise to the brain, but it has some more serious consequences. So I'm just going to go through a few examples of concussion. You might be able to hear it. So this was Jack Riewoldt a few years ago. So if it wasn't obvious there that he had a concussion, we'll see in a sec. So he hits his head quite hard on the ground, and then some staggering sort of movements, and then really not quite being right. I don't know if Jack Riewoldt would normally crawl up the race when he's trying to get back on the field, and then having a bit of an argument with the doctor. So yeah, it can be just, if you hadn't seen that knock, so often in local footy, not everyone's watching every single player, but if someone doesn't quite seem their normal self, staggering off or more argumentative than they'd normally be, then you've got to have a suspicion for concussion. This one's probably more, I don't know if you can, probably can't hear it so much, but so this was Dylan Robertson a few years ago when he had a post-match interview. Wasn't diagnosed with concussion during the game. Someone missed that. So he got a knock to his head, and then it also could have been when he landed quite quickly and his head decelerated back and forwards. And so yeah, again, he was quite confused after the game, treated as a concussion later on. If you watch the North Melbourne player, And so that was back in 2020, you can tell because there's no crowd there when we had COVID. And that was an old sling tackle, which hopefully has been sort of ruled out now. AFL isn't the only sport we see concussion. We see concussion in lots of other sports. So we do see it in netball, basketball, that top right's hockey, also in soccer. And they've also, I think in junior soccer, made some rules where you can't head the ball until you get to a certain age because that's thought to increase the risk of developing concussion. And so if we look at the sports that increase your risk of developing concussion, so it's quite tricky to know the exact rates of concussion. The only real way we know is by looking at the hospitalisations. And so this was in 2020, 2021, and the most common sports, as we'd sort of would have thought, is AFL and rugby, but also cycling, roller sports, and that's not just competitive, that's kids coming off their bikes, off their rollerblades. So we've got to sort of be aware of concussion in lots of different sports and activities. And then if we have a look at the age group where we most commonly see concussion is mostly younger people, so mostly in males, probably more males playing AFL, and then under the age of 25. How do we diagnose concussion? Well, unfortunately there's no real blood test or procedure like a colonoscopy for bowel cancer. It's really a group of symptoms, and maybe that's where Port Adelaide got it wrong on the weekend. It can be any of these symptoms, and so we have to have a really low threshold for diagnosing concussion. Any of these symptoms could be concussion, and I think I mentioned most of them previously. So really any of the concussions, we've got to have a high threshold of diagnosing it. So why do we care about concussion? Well, you have some immediate effects, so you might not be able to play or perform your sport or your work or your school as you normally could. And then also some short-term effects, so difficulty concentrating, poor sleep, and can lead to changes in mood, so increased prevalence of depression and anxiety. We also know that the more concussions you have, the lower the threshold is, so the more likely you can have a lighter knock to your head and develop concussion. And then you can have some prolonged symptoms after a concussion, so headaches, dizziness, blurry vision, poor concentration, and the recovery is very variable. It's different for everyone. Some people recover the next day, other people can have symptoms after that initial knock for up to 4 weeks. And again, the more concussions you've had, often the more prolonged your recovery is going to be. As we've said, it's sort of a bruising to the brain, and the more concussions you have is associated with poorer outcomes longer term. And so we're really just finding out the past 5 years or so what some of the long-term effects of concussions. So Polly Farmer and Danny Frawley, we now know, had quite a few concussions and led to permanent brain injury. Shane Tuck from Richmond, we're suspecting that, and there's an inquiry going on at the moment in Victoria. And then AFL is launching a class action, and we're a bit concerned that that might follow down some of the other more junior ranks of football. So why do we care about concussion? Well, it has quite significant long-term effects, so long-term headaches, memory losses, and we also really don't know. We're really just finding out now what some of the longer-term consequences are. And we do know it's associated with dementia, so longer-term memory problems, Parkinson's disease, so I don't know if you remember Muhammad Ali, he had repeated concussions which led to his Parkinson's disease, and then also seizures. And so concussion is longer term can lead to what's called chronic traumatic encephalopathy, which is really just permanent brain damage. You can see down the bottom right, that's or the top one is a normal brain, and then the bottom right is of what a brain looks like that's had repetitive concussions. And so initially it can lead to memory loss, change in behaviour, then you develop some of the Parkinson's disease and cognitive impairment. And so one of the questions is, well, how many concussions can you have before you're at high risk of developing the long-term effects? And again, we don't really know. My sort of recommendation is once you have 3 concussions, you really need to then rethink about whether you keep exposing yourself to that risk. But there's been plenty of people that have had 9, 10 concussions, probably more, and have led to these long-term effects. How can we prevent concussion? Well, we don't have too much information on prevention. Helmets don't work. They just prevent against soft tissue damage, so lacerations to your head. Mouth guards, there's some evidence that they might work and they could absorb some of the shock when you get a knock to your head. There's some interesting studies going on in Victoria at the moment where they've implanted some sensors inside mouth guards and then also looking at inside helmets to pick up how much force is required to cause a concussion, and then that might flag to the AFL whether a player should come off and have a concussion test, maybe not by a Port Adelaide doctor but by someone else. The AFL have actually designed mouth guards for AFL players to wear, and every single AFL player has been fitted with a mouth guard, but only about 5% of players actually wear this mouth guard that's got the sensors in it. So with the inquest into Shane Tuck's death, I don't know if many of you know him, but he was a player for Richmond who took his own life a few years ago and had repeated concussions and has been found to have the chronic traumatic encephalopathy. And so in part of that inquest, they're looking at some funding and some studies to see can we detect concussions earlier and prevent these long-term effects. And way to prevent concussion is looking at rule changes, and so when we looked at that North Melbourne player who got the concussion with the sling tackle, that's now been outlawed and quite heavily penalised in the AFL, and hopefully that will follow on. I think there's still a bit of that in our leagues around here at the moment, but hopefully that will follow down. So what do we do when we have someone who has a concussion? So one of the important things, and hopefully tonight helps people to be able to recognise when someone might have a concussion, and having a really low threshold of diagnosing a concussion and then making sure that the player or the person is removed from that situation so that they're not putting themselves at further risk. The other important thing is then to get that player or person reviewed, because not every injury is a concussion. So concussions can sort of mask other injuries, so spinal cord injuries, bleeds on the brain. We had a player last weekend at Crystal Brook and Jamestown who got, in the last quarter, got quite a heavy concussion. He had quite severe neck pain. He went off. Luckily all his scans were okay, but there was a suspicion that he could have had a neck injury. So a really important thing is that every person who is diagnosed with a concussion or suspected of having a concussion has a medical review that within 24 hours. And so the next step is then resting, and you've got to give your brain a fair bit of rest to recover from the concussion, otherwise you're susceptible of not recovering back to your baseline and putting your brain at risk for future concussions. And there was an interesting study done, I can't remember what year that was, but they looked at what do local community players think of concussion. Most players seem to be aware of the importance of concussion, but a lot try to mask the concussion because they think the most important thing is winning their local games of footy. And so hopefully with more research, with more publicity, education, that we can reduce the risks of people developing longer term negative outcomes. So no wonder Port Adelaide got it wrong, because this is the AFL's flowchart of how to manage and diagnose a concussion, which was brought in at the end of last year for this season, which I think is impossible to read. So then we have Australian guidelines, which has been developed by Australian Institute of Sport, and so this is for adults. So if someone gets diagnosed with a concussion, there's no return to sport. They have to rest their brain really important to also rest their brain from work and or school. And so that's for 24, 48 hours until they're asymptomatic, and then slowly move through the steps of returning back to light activity. If you can do that for 24 hours, then you can return to basic sport drills. So in football, that would be lane work like kicking and handballing. Then again, asymptomatic for another 24 hours, can do more complex sport drills where you have to think a bit more. And then they must have a medical review before returning back to full contact training. Then they can return to full contact training, and if they recover after that, then it's back to sport. So AFL has a mandatory 11 days, which is why they made that flowchart so confusing, so that they could string it out to 11 days. Really for us here, it's about 8 days is the absolute minimum if you're asymptomatic the next day, so symptom-free the next day. For kids, it's a little bit more complicated, but they can't return to any contact activities until 14 days after the complete resolution of symptoms. So it can progress through to light activities, some sports-specific drills, but can't put themselves at risk with full contact until 14 days after. So usually, for us locally here, it's at least minimum of 3 weeks of no contact or not playing football. And then there's a really good app that's just been developed. So if anyone or anyone's kids or involved with the football club or netball club has someone that has a concussion, you can download this app, free app, which has been developed in Australia and worked through the guidelines of returning to sport and also returning to school, and then it can help you detect if there's anything concerning where you might need an earlier medical review. So hopefully provide a bit of information on concussion. Hopefully I've done a better job than the Port Adelaide doctor did last weekend. I was quite surprised because in the AFL, you know, the doctors have the videos that they can watch on replay. There's also someone who sits in the ARC, the score review, who's a doctor who watches every bit of play, and then if they suspect someone has a concussion, they contact the team doctors on the ground to pull that player off for an assessment. So I don't know, I'm not sure why things went amok a bit last Saturday night, but I think Port Adelaide's now paying the price. So hopefully we can do a better job out here than they can. Any questions or things you want clarified? Yeah.
Simon, how do you tell the difference between long-term concussion, effective long-term concussion 20 years, 30 years later and just normal aging? You know,
during an autopsy.
Yeah.
When it's all too late.
Yeah.
We can't really, I suppose there's no real way of stopping that deterioration. It's more so treating the symptoms of that person develops. So there may be some scans coming out now which might be able to detect whether someone has long-term brain damage from concussion. So I think it's his name, rugby player Wally Lewis, I think it was. He was on some current affairs or something like that they said they were pretty certain he has some permanent brain injury from repeated concussion. So there's probably going to be more scans. It's a very heavily researched area at the moment, and I think as things progress we'll learn a bit more about diagnosing earlier on.
Is there any memory loss? You know, a few hours you can't remember or something like that? There's no mention of it.
No, so yeah, often there is memory loss. Doesn't have to be memory loss, but there can be memory loss. So this poor Crystal Brook player, it was his 8th A grade game and it was the first goal he kicked in A grade and he has no recollection of it. But yeah, often there is memory loss, and often that period of time they don't remember at all ever again what happened just prior to the concussion.
You've concentrated on sport, but what about little kids from the time they can walk? They're always falling over and hitting their heads, and they get big lumps come up, bumps come up, and from the age of 2 to 10. Is there concussion involved there? Like, you just don't know?
Well, we don't really know, but probably unlikely, because young kids are developed with very big heads and quite solid heads, and they're designed to protect against concussion and injury. So again, it's if they don't quite seem right, it could be a concussion. But most kids, if they fall over and hit their head, are usually, you know, they might cry for a bit. They're usually not too bad afterwards. But yeah, we don't really know.
A kid can have a lump the size of a pigeon's egg.
Yeah.
If an adult had a lump, that
yes, you'd be quite worried. Yeah. So no, we don't really know. And again, that could be adding to the cumulative concussion that someone's experiences in their lifetime that puts them at risk of longer term damage.
And further to what Jim said there too, you say you have a work accident, say a wheelbarrow comes off the front end loader and pushes the bloke off the truck, etc. He's a bit groggy, but he gets back up and works again. How should we really be treating that situation? Should we, if he is a little bit groggy, or do you presume he should be checked?
It should be checked, yeah.
If he's worried and take him away from that work environment.
Yeah, it should be checked out, just like a...
More than likely the truck itself, and he'll want to get it loaded.
Yeah, that's right. It's like most farmers keep working even if, you know, half an arm's falling off. But yeah, should get checked out. And again, you know, we see plenty of concussions from workplace accidents. It's not just AFL and sport that we see concussions, and again, that adds up to the concussions that someone's experienced in their lifetime. And they should be managed exactly the same. Workplace concussion: rest, resting from work, resting from TV, phones, iPads, until their brain starts to recover properly, and then gradually returning back to work.
And it'd be better to receive that information to get the rest from ED or something like that. Bring them in hospital.
Hospital or GP practice. Yeah. Any other questions? No. All right, hopefully that was informative.
Excellent, thank you very much, Simon. So I've got the pleasure of introducing Dr. Sam Costello, and Sam, did that just go forward? And Sam, I think I first met when I was doing internship. I was new to the Royal Adelaide and on night shift, and poor Sam had me as an intern. He must have thought, jeepers, what the hell have we got here? Because I wasn't good, and I was in a mad panic. I was running from ward to ward in the middle of the night, really like a chook with its head cut off. I was in a lot of trouble, and I had Sam, very calm, and another registrar there to help. And then I've been fortunate to work with Sam over the years, as we've both done gastroenterology. And Sam being a lot wiser than me, a year older than me, but it's been fantastic to work with Sam. I'm also going to cheat with a bio for Sam, but Sam graduated from the medical school in Adelaide in 2004, and then completed basic physician training at the Royal Adelaide, and then followed by gastro training at the Queen Elizabeth Hospital and the REPAT. He undertook a clinical fellowship in inflammatory bowel disease at St Mark's Hospital in London in 2016. Having worked as a consultant gastroenterologist, both public and private, his time now is predominantly focused on being the managing director and co-founder of the Biome Bank, which I'm sure we'll hear more about tonight. So thanks very much, Sam. Give a warm welcome.
Thanks, Alice. Took me a bit longer to get through training. I think we finished at about the same time in the end. So, I'll just... so my talk tonight's about the gut microbiome, so the bugs that live in our gut, and then the therapies, how the loss of these bugs can cause disease, and how we can, if we replace the bugs, we can treat disease. So we do have this large population of bugs that live in our gut, and that's called the gut microbiota. And sorry, I'll put that back on. And we really depend on these bugs for our health. So they perform many important functions for us. They help us digest our food and maintain the lining of the gut. They help educate the immune system. And we've really evolved with these bugs over millions of years, so that we depend on them and they depend on us. And many of them are only found in the human gut. And our gut can't work if we don't have these bugs in our gut. So we've really only appreciated this in the last 10 years or so, the importance of this. And so it really gives us an appreciation of some of the diseases that we know about, but also new ways to treat them. So how do we pick them up? Well, the only way that these bugs get into our gut really is if we eat them. So, or we consume them in some way. And the first chance we do this is during the birth process. So you can see on this top slide, these little pictures, little blobs are a pictorial representation of where someone's gut microbiome sort of, how similar it is to another microbiome or another group of bugs in a gut. But you can see that these are a baby's microbiome and the mother's. And babies born via caesarean section have a gut community that looks a lot like skin, whereas the babies born via vaginal delivery have a microbiome that's much more similar to the mum's gut, essentially. And so it does seem that it's important that early acquisition, because if you're born by caesarean section, then you can have a risk of a number of diseases later in life, like a slightly higher risk of allergies and things like this. So the early acquisition is important, and there are a whole range of things that impact this. So diet, breastfeeding, antibiotics are an obvious one. If you have large numbers of antibiotics early in life, there are risks for a number of problems later in life, and we're just really understanding that more now. And what could you do really to help? Well, probably diet is the biggest thing. If you're eating a high fibre diet, that's the best way to maintain the community, because that's really what these bacteria need. So we also know that modern humans living a modern lifestyle have a lot less gut bugs in our gut now than we probably did 1 or 2 generations ago. So if you look at communities living still more traditional lifestyles in, say, Africa or South America, these populations have much higher levels of bacteria in the gut. So those green dots up the top, this is just the number of different species in the gut, versus the blue in an American population is a lot less. And you can see that over time, over the last 50 years, we've had almost eradication of a lot of infectious disease during that time. So antibiotics have been a great win in that regard. Sewage systems, clean living. But during that same period of time, we've had a massive increase in many of these other diseases. Not all of these are caused by loss of gut bacteria, but it is, I suppose, a smoking gun that the loss of these bugs might be contributing to disease. And we know that essentially the community in the gut's like an ecosystem like any other, like a rainforest. Say this is Em, who's going to be talking next when we're in South America, but it really is it is like this. All of the different components depend on each other, and so if you lose some critical elements, you can have a widespread damage to the whole system. And things like antibiotics, like really strong antibiotics, can cause a total wipeout of these communities. And in that case, you can get a normal regrowth, say the forest can grow back, or you can get a situation where you get a regrowth of weeds. And one of the weeds that's the most common problem after antibiotics that we would see people hospitalised is called C. difficile infection. So this is a nasty bacteria that can overgrow the bowel after antibiotics. The problem with this bug is that antibiotics are the treatment for it as well, and so they can often effectively treat it, but it keeps coming back because your native gut bacteria are also missing, and so there's nothing there to really to fight it off, and so it keeps growing into that niche. And so this is a picture of what it looks like to have C. difficile. It's these you might have seen that picture Alice had up before of a more normal bowel, but this has got these yellow plaques, and that causes inflammation, diarrhoea, and can even lead to people losing their bowel. And the good news is, though, that if you put back that community of bacteria from someone else's bowel, so you get what's called a fecal transplant, where you collect stool from someone who's healthy, put it into the bowel and repopulate those organisms, you can actually treat C. difficile. So it sounds like a filthy business, and it is, but there's now a whole standardised process for doing this, and that's what we do at Biobank, which is the company we have in Adelaide. So we collect the stool in a bag in the toilet, process it, and then put it into a syringe and deliver it into the bowel. This infection is really quite a major problem. So there's up to close to 30,000 deaths in the US every year from this disease. And antibiotic therapy fails in probably 20 to 30% of cases. So this offers a cure where antibiotics are failing, and in that case, patients would often end up losing their bowel. So this is a patient of mine who had this C. diff, which was all that yellow material there, and you can see after a fecal transplant, it's back to normal. And this is the scientific study which showed that it works. And essentially, but the bar on the left is the patients who got a fecal transplant, so you can see about a 90% cure. And this is the traditional antibiotic therapy on the right. The patients who got that therapy had about a 30% cure, so a massive difference, massive benefit of fecal transplant over the antibiotics. And this is the patients getting this service now in South Australia. So really started the service in 2013 with a couple of patients, and year on year it's increased. Still not huge numbers, but 30 to 40 patients a year get the service, and those patients often would have previously had surgery. And we now supply about 40 hospitals around Australia with the same product. So over about 180 patients have been treated now, and we get a cure rate of over 90% for this treatment. Another disease that we have been able to treat is ulcerative colitis. So this is a inflammatory bowel disease where patients will present with diarrhoea. It's often bloody diarrhoea. This occurs often in young people, so often onset between the ages of 20 to 40, and patients will have a lifelong problem of having constant diarrhoea. The traditional therapy for this is immune suppression, so giving medicine to suppress the immune system, but in about 10% of patients these therapies fail and again would need surgical removal of the bowel. So we tested fecal transplant in this condition, and we did a trial where we gave half of the people the fecal transplant and half of them got nothing for 8 weeks, and we essentially showed that, again, quite a decent difference between the two groups. So the people who got the fecal transplant had a remission in about 30% versus 9% in those who didn't. So this is possibly going to be a therapy for people in the future with this disease. So what about probiotics? Well, probiotics are bacteria that could potentially be found in the human gut. The major issue with probiotics that we have available at the moment is they're just very limited in their in the diversity. Really, there's only a couple of different strains you can get: a lactobacillus or a bifidobacteria. These are things that you often find in yogurt. But this is the sort of family tree of all the bugs that can be in your gut. There's many hundreds of them, and lactobacillus is just one little tiny sliver here. So the problem that we have with the currently available probiotics is they're so narrow, it's sort of like putting a a koala into that forest that's been wiped out. It doesn't have everything it needs to survive. It needs it needs the trees and everything else there. So we need more of the community. So the whole donor material provides that whole sort of ecosystem that works really well. And so really what we're trying to do at Biobank is we have a donor-derived therapy, which is the fecal transplant, which is given into the bowel. We'll have a capsule available soon, just freeze-dried capsule. We're then trying to actually grow these bugs in a bioreactor, so you can grow it in the lab and you don't need donors. And what we're really aiming for is a real diverse community, so the whole breadth of bacteria rather than just the single strains that are in the chemist at the moment. And so these therapies would be scalable because you can grow them in the laboratory and not require donors. And so what we're really working on is this idea that we could grow them all in the same community, and so you could have potentially a highly effective therapy that you could produce cheaply and manufacture and then supply not just to people in Adelaide and in South Australia, but to around the world. And so this is a bit of like a diagram about how we sort of pick the bugs that might go into this therapy. So we can do a study with the fecal transplant like we did before, comparing people who get the therapy to those that don't. And if those patients who get the therapy improve and get better, we can look in their bowel to see which of the bacteria are associated with getting better. And then we can grow those bacteria and then combine them into the bioreactor, grow them together, and make a sort of artificial fecal transplant. And that's the process we're working on at the moment. And so we have that top therapy is the fecal transplant therapy that's available and approved in Australia now. And the lower down, there's these cultured therapies, and they're at a really early stage of development. But we've got them growing in the lab, and we'll probably test them in people next year. So that's it. Has anyone got any questions?
Is there any, apart from overuse of antibiotics, is there any other reason for the decrease in gut?
Yeah, I think there's probably a lot of reasons. I think one of them is diet. So essentially most of these bugs need fibre. That's what they use for their energy source. And the fascinating thing for me about them needing fibre is that the cells that line our gut require the breakdown product of fibre. So the fibre come in, bacteria consume it, and they spit out a thing called butyrate, which is a short-chain fatty acid. And the cells that line the gut, they use that as their energy source, and almost all the other cells in the body use glucose. But these cells only really use that breakdown product of fibre, so the whole sort of system is linked. And so the modern diet has really low fibre compared to what even 2 generations ago would have eaten, and because a lot of processed food. And so I think that's one of the big reasons. The other thing is there's less opportunity for transmission between people, so the relatively clean way we live at the moment, which is good because you don't catch cholera off everyone, but you also don't have the opportunity to pick up a whole lot of the good bugs. And there are a number of other things, caesarean section rates are, say, a lot higher than they would have been in the past. And there's probably a whole range of things that we don't appreciate as well. Just the world's changed a lot in the last 100 years. Yeah.
And there seems to be a growing incidents of people that are gluten intolerant.
Yeah.
So what's going on there?
Oh, look, that's a tricky one. There's celiac disease, which you can see, you know, damage to the gut lining. There's a lot more people that report gluten intolerant that aren't celiac. Look, to be honest, I don't know, but a lot of them have what you'd also might consider irritable bowel syndrome, so they get bloating, they don't tolerate, whether it's wheat or gluten, it's hard to know. There is actually really good evidence now that people with irritable bowel have a certain pattern to their microbiome. They're missing a certain group of these bugs. So there's basically two groups of bugs in the human gut, and they're called like firmicutes and Bacteroidetes, but half of them are spore formers, basically. They're really hardy, and you'll find them around, you know, everywhere. They'll be on the tables here, everywhere. And that's how, and we ingest them, and you'll ingest everyone else's bugs. But because they survive in the environment, you can do that, and we do transmit those ones pretty well. The other half, though, are really oxygen sensitive, so they don't survive in the environment at all well. And if you lose them early in life, they're gone. And these are the ones that are missing in many people with irritable bowel. And it does seem like it's that loss that's causing it, and maybe all those factors we were talking about, maybe why people are getting irritable bowel, and they might consider themselves to be, you know, gluten intolerant. And I wonder if that's a bit of it. But yeah, it is a bit of a mystery. We're hoping that via these methods, though, we can grow those bugs and put them back. So if people in the future have a problem like that, we can go to the shelf and actually pull off, you know, a therapy that has 100 of these different things that you might need, that you might be missing, and just replace them instead of needing a fecal transplant or nothing at the moment. Yeah, or just the random acquisition from the environment.
There's no evidence that the gluten in modern wheats is different from the gluten.
I don't know. Yeah, I don't know. Don't know. It might be. It might be. You would know more about that than me, probably, I'm sure. Yeah, I've had the odd patient, you know, I mean, this is anecdotal, but go to Europe, go to, say, Italy, and say, oh, I can eat the bread there, but can't eat it here. And I don't know if there's anything in that at all. If there's different types of wheat around the world, I'm not sure. But, yeah. Or if it's even the gluten they're sensitive to, truly. Yeah.
The ability to make these microbes. What about testing which ones, say, for myself?
Yeah.
Will there be a test like else's blood? You'll do a test with the poo and you'll say, this is what you need.
Yeah. So the testing's actually more advanced than the therapies, the therapeutic development. So actually, you can actually get tests. There's a company called Microba in Queensland that will do a test where they can, with pretty good precision, work out what you've got and what you don't have. The problem at the moment is that they can identify what you might not have, but there's no method to replace it.
Yeah.
Save, you know, getting a whole fecal transplant, you know, like the entire community from someone else and putting that in there. There's no rational way to do it, you know, like a precise way. So we've got about 30,000 different isolates in our bank of organisms. So we've actually got most of what you might need, but to get that into a therapy is many steps. And so, you know, there's all the trials and approvals and all that stuff. So I think it will come, but it will take a while.
It'll be something you use, that'll get used fairly well with the babies too.
I think so. I think, yeah, absolutely.
Get that up and going from the start, especially while mum's still there.
I think you're absolutely right. Yeah, I think that's if you were ever going to do it, that would be the time. Yeah, early in life. Yeah. Exactly. Yeah, I think so. Yeah.
If later on in life you start getting allergic to stuff or you can't handle the same stuff, would that be a cause from having a lacking gut diversity?
Yeah, I mean, it might be. So there's a lot of association studies, like when people have problems like this, if you look at their microbiome, often they're missing bits. That's not conclusive proof that it caused that problem, because of course it could be that you just, you know, for some other reason lost them, but it's a consistent pattern, I suppose, and particularly disorders like allergy and autoimmune disease, that there might be missing bacteria, and whether replacing them now will fix it, or whether it's sort of loss earlier in life that's the problem, it's not clear, but I think there's a lot of research going into that. Yeah, so I think that there will be therapies in the future, either to replace it early on or to try and prevent those problems, or even to intervene later when you know, with a test that might pick up what's missing and be able to replace it.
Hey Sam, I quite often get told by people I'm full of shit. If you're looking at opening a
yeah, we get a little mobile donation bus come up. Yeah.
Couldn't guarantee the quality.
Frequency, yeah, that's it.
I get asked at work a lot about what type of diet should I be on, and obviously there are some people that need to be on a gluten-free diet and what have you. We know fibre is important. Is there any overarching diet that is more healthier? Is it the Mediterranean diet that we should be sort of focusing on for health, or is it really just an individual type of thing to?
Oh yeah, I don't know. So, I mean, I think like high in vegetables and fruits and fibres, whole foods is probably that would be the thing I would say. I mean, yeah, just looking at it from the bacteria's point of view, that's what they want. But I mean, and I think like, you know, people the gut is essentially designed mainly to handle, you know, fibre, fruit and veg, and that's why you have a big, large bowel with a big cecum. Like that's the point of, essentially, if you look at different animals and how their guts are designed, ours looks more like a herbivore than a carnivore. We're designed to be able to eat meat and eat some, but not the volumes probably people eat now. And so, you know, you talked about bowel cancer, and that's probably part of the issue there, I think, as well. So, yeah.
Thanks very much, Sam.
Thanks.
So Emily is the other half of the powerhouse couple, Sam and Emily, who've come up this evening from Adelaide. So Emily was a couple of years above me, or a year above me, at the Royal Adelaide as well, and I used to admire Emily. She was and still is extremely smart, and I probably look like a headless chick to her as well. So, but Emily is an infectious disease consultant and has come up today to speak to us about Q fever. Emily was very humble. Well, no one really gave me their bios, so I really had to do some hunting, but she's very humble and said hers wasn't very exciting, but I really do think it is. But so Emily is an infectious disease consultant with expertise in clinical infectious diseases and epidemiology. She completed a degree in Adelaide and completed then her basic physician training at the Royal Adelaide Hospital with advanced training in infectious diseases in Adelaide. She currently holds a consultant position at the Royal Adelaide Hospital and Queen Elizabeth Hospital, and also has established an overseas biome banks donor screening program. So please make Emily very welcome.
Thank you. Yeah, so part of my job is to make sure that the people that provide stool for FMT are safe and suitable to do so. And then in the other half of my work, I try and kill as many bugs as possible. So, so today I thought I would focus on Q fever. And just a little overview on zoonotic diseases. But before that, I was just reflecting on my time 20 years ago when I was a medical student up this way. I was part of a pilot program in 2003, in my fifth year of medical school, where we spent, where they tested out whether you could actually, give the medical school program in the country for a year. And so there were 10 of us that spent our year in 2003 in Bullery Centre, Port Pirie, Port Augusta and Port Lincoln. And it was quite hard to find anything on the internet from 2003, but I found this article where I quite nerdily said that I had a lot of time to study while I was there. I don't actually remember doing that much study. We had a wonderful time. I remember playing netball for the BMWs and getting involved in darts competitions in the pub, and also learning a lot of medicine and really learning a lot about, I think, the barriers of living a long way away from metropolitan areas in the sense of access to testing, investigations, specialist care, etc. And I do also remember watching the GPs doing some of the Q fever pre-vaccination screening with the skin testing and blood testing. I was thinking about that when I was putting this talk together. Yeah, so I may well have seen some of you 20 years ago. So initially, zoonotic diseases are diseases that can be transmitted from animals to humans, and certainly something that people have probably heard more about with COVID, which I promised Alice I'm not going to talk about tonight. There's nothing about COVID in this talk. But it particularly affects people that live and work around livestock or wildlife. And, we really do see that a lot of the emerging infectious diseases come from places where people particularly live near jungle fringes, where there are wet markets, wildlife markets, etc., in places where diseases can move back and forth between humans and animals. And it's really important because zoonotic diseases can quite commonly have longer-term health consequences, and so it's really important to take as many measures as possible to try and prevent transmission. 60% of existing human infectious diseases have animal origin, and 75% of emerging diseases have an animal origin. And these are diseases like Ebola, human immunodeficiency virus, or HIV, and influenza. 5 new human diseases appear every year, and 3 of those 5 are of animal origin. And these are often really important diseases to be aware of in the areas of bioterrorism, because they're diseases that can often transmit quite easily and have some of the properties that make them good for really causing mass transmission. So they can spread by direct contact, and so that includes skin infections such as ringworm and bacterial diseases that can infect humans through entry through cuts and wounds and mucous membranes, etc. And examples of these are infections like leptospirosis, human bacillus, which is effectively rabies, and ORF, which I'm sure all of you potentially know more about than me. Aerosol transmission, so that's breathing in the bacteria or virus, and Q fever, which I'm going to talk about today, that's a primary mode of transmission. Ingestion, so consuming the bacteria through eating contaminated food or water. Examples of this are those common food poisoning bacteria like Campylobacter and Salmonella. And then insect bites are also potentially considered zoonotic diseases, and so these can transmit diseases straight into the body or bloodstream. And examples of this are Ross River virus, Murray Valley encephalitis, and more recently with warmer climates and some changes in our local epidemiology, we've seen Japanese encephalitis in South Australia in recent years as well. So to minimise risk, obviously keep livestock healthy and vaccinate them where you can for zoonotic disease. Unfortunately, there aren't a lot of vaccines available. Examples include leptospirosis and Hendra vaccination. Also ensure you're vaccinated against any zoonotic diseases. Again, there's only limited opportunities for vaccination. Examples of this include Q fever vaccination. There is a Japanese encephalitis vaccine available as well for high-risk people. Wear personal protective equipment where possible, and then cover any wounds with watertight dressings, and take protection against mosquitoes and other biting insects. And make sure you wash your hands regularly, especially before eating or before preparing food when you've had contact with animals. So more specifically about Q fever. Q fever was first described in Australia in 1935, and it was first found after there was an outbreak of an illness associated with fever in a slaughterhouse in Brisbane. Interesting, almost at exactly the same time there was an outbreak that was occurring in the United States, and the disease sort of emerged in Australia and the United States at around the same time. It was originally known as Curie fever, as the cause wasn't known, but later it was found to be caused by a bacteria called Coxiella burnetii. And really the reason why it was quite hard to actually work out what was causing Q fever is that it's a bacteria that only survives inside cells in the body, so it's very hard to actually detect. And so it required very special testing to actually see that this was a bacteria that was living inside the cells, whereas normally with infections you are able to see it sort of free, you know, in the blood or whatever body fluid you're looking for the bacteria in. And so for a long period of time actually it was thought to be a virus, but it is in fact a bacterial infection. And it naturally infects mammals, birds and ticks. So studies have suggested approximately 1 in 20 people in Australia have been exposed to Q fever, and that number can rise depending on you know, areas where potentially people have more contact with animals. In North Queensland, the percentage of dogs presenting to vet clinics with Q fever antibodies was close to 20%, and that was the same for cattle in that region as well. In Western Australia, a study found that almost 25% of Western grey kangaroos had detectable Q fever antibodies, and that the bacteria was found in 4% of faecal samples tested for Q fever, which, you know, suggests that, you know, there's a reasonable amount of active infection. And it's thought that these Western grey kangaroos are a really important reservoir of Q fever. And in fact, some of the cases that I've seen in recent years have actually been people that have been camping around kangaroos. But, you know, as you can see there are lots of different wild and domestic animals that can be infected with Q fever. And ticks are also a really important vector in the transmission cycle in these reservoir species. Generally known as a reservoir species because they don't generally get that sick from Q fever. It's a virus that, bacteria that's latent and so is present but not causing illness in animals. One of the really important and most infectious times for an animal with Q fever is during the time of birth. And so, you know, that's when you can see really high shedding of the bacteria, and there are millions of bacteria being released per gram of placenta. And that's really important because one of the key things about Q fever is that it has an extremely low infective dose. You only need 10 to 15 organisms to actually cause infection in a human. If we look at something like salmonella infection, you need 1,000 to 100,000 bacteria to cause an infection. So this is something where really you only need to see a small amount to actually cause disease. The other thing, and so it can also be found outside of birth products, in urine, faeces and the milk of infected animals. Q fever is really hardy as well. It is resistant to heat, drying and many common disinfectants. So it can live for a long time in the environment. It's able to survive on wool at 15 to 20 degrees for up to 9 months, and in refrigerated conditions on meat for more than a month. And it can remain dormant in soil and dust for months to years. So you don't need direct contact with an animal to acquire Q fever. And most people get infected by breathing in dust contaminated with infected animal faeces, urine, milk or blood products. Birth products, sorry. And it's able to travel, several kilometres on wind. And so you may not actually even be close to animals. You can live downstream from an abattoir or a farm and be at risk of exposure. And it can also be stirred up with vehicle movements and activities like lawn mowing. Less commonly, it can be transmitted by eating contaminated, unpasteurised dairy products, and then rarely by blood transfusion because it can be present in your bloodstream. A pregnant woman could pass it on to a fetus, and it can be transmitted via sexual intercourse, but all of those are rarer causes of transmission. And transmitting from one person to another is rare. It's usually transmitted via animal to human. And because of its very low infective dose, the fact that it is hardy, survives in the environment for a long period of time, and it can be aerosolized easily, it's considered a potential bioterrorism agent. So, unsurprisingly, vets, people that work in meat processing plants, farmers, and people that work in research areas with sheep and goats in particular, as well as with wildlife as well, are at high risk of acquiring Q fever. And generally it takes about 2 to 3 weeks to develop symptoms. And as you can see from the list of symptoms you get with Q fever, it's what we call a very non-specific illness. It's fever, chills, sweats, muscle aches, nausea and vomiting. These are sort of things that you can have, with all sorts of different presentations. So it's not always obvious, and a lot of people have Q fever and never realise they've actually had it. And you can have a mild illness or you can have a more severe illness where you end up with something, where you can end up with pneumonia or inflammation of the liver, hepatitis. Women who get infected during pregnancy are at risk of having pregnancy-associated complications. It is important to note that the case fatality rate, if you have untreated Q fever, is still very low. Chronic Q fever is a really important complication of Q fever that is rare, but important to be aware of, particularly in certain groups of people that are at higher risk. And it takes months or years to develop. And really it's people who have issues with their heart, particularly heart valve issues, or people whose immune system doesn't function very well are at risk of developing this chronic problem. And what it can do is it can cause either a problem in your heart valves called endocarditis, which is an infection on the heart valves, or it can cause an infection in the bones or the blood vessels. And it is really a very serious problem and requires quite a complicated course of antibiotic treatment that in general goes for about 18 months. This is a little bit more of a controversial area, but Q fever is one of the infections which is associated with a potential post-infectious fatigue syndrome, which can incur in up to 10 to 15% of people who have Q fever. And it's defined as somebody who fails to really recover from Q fever more than 12 months after they've had the infection. And it's really sort of in those sort of chronic fatigue-like presentations, it's really challenging to diagnose and very unclear how to treat. But it is a very well documented issue that can happen after Q fever. In general, Q fever is diagnosed with a blood test. And that blood test, takes a little bit of time to come back, particularly if it's, sent from a distance away. And so, if you've got a clinical picture that's very suggestive of Q fever, you may well get started on antibiotic treatment before that diagnosis comes back. And then, if the diagnosis is not Q fever, then the antibiotics are stopped. So, like I said before, most people who get sick with Q fever will recover without antibiotic treatment. However, if a diagnosis is made, then the usual treatment is 2 weeks of an antibiotic called doxycycline. But if you have the chronic version of the infection, then you end up with a more complicated course of treatment. In general, once you've had Q fever, the thought is that your immunity is lifelong, but it's that's not always the case, but in general it's considered that once you've had it, you'd be unlucky to get it again. Antibodies, so evidence of immunity in your blood, are detectable for about 3 to 5 years after infection, but may last as long as 15 years. But that's really important to be aware of because these levels of antibodies that are detectable in your blood will disappear slowly over time. And so you need to be aware of this if you're being checked out for suitability for vaccination, because if you've had past Q fever, then it's risky to be vaccinated and it's strongly recommended not to be vaccinated. There's a different type of immunity called cell-mediated immunity, which lasts for longer than this antibody-mediated immunity, and I'll explain why that's relevant in a moment. So in Australia, there is a vaccine available, and many of you may well have been vaccinated. It's been available since the late 1980s. In a lot of countries, including the US, a vaccine is not available for Q fever. It's 83 to 100% effective in preventing the disease, but it's currently only licensed for people over the age of 15. So prior to immunisation, you need a blood test to check for antibodies to see if you've had past Q fever infection. And then you also need a skin test, which is an injection just under the skin, and subdermal test, and that looks for the cellular immunity. So whilst you may not have evidence of antibodies, you may have evidence that you have had Q fever based on that skin test, which is why you need the 2 types of tests performed. And in addition to that, you need to have a chat with your GP about whether or not you've had any particular evidence of past infection that might have been treated before. And the reason for this is that if you have had past Q fever, then there's a very there's a risk of having a severe reaction to the vaccination, and so as a result, you're ineligible to be vaccinated. And ideally you should be vaccinated at least 15 days before you went to a high risk environment. There's a long list of people where Q fever vaccination is recommended for, and again, it's really people that have close contact with animals. And so how do you prevent getting Q fever? Well, really prevention is obviously the most important strategy, and that includes staying clean when working with animals, so wearing protective clothing. I think people learned a lot more about the value of face masks, and then I think after COVID, the numbers have sort of disappeared. People have been less keen on it, but really, a face mask is a really important way of preventing transmission, given that the bacteria is breathed in. It's the most common way of being exposed, particularly those birth products that are really can have the potential to have a lot of bacteria present in them. Ensure that people who work on livestock sites are vaccinated. Unfortunately, in Australia, as far as I'm aware, there is not a vaccine available for animals for Q fever. In Europe there is, but it's not available in Australia. My understanding is that that's because the vaccine is manufactured in a facility where there are other live vaccines being manufactured for diseases that aren't present in animals in Australia, and there's too big a concern that those, if we brought that in, we could bring in diseases into animals into Australia that don't exist here yet. So obviously, really taking care after handling animals with regards to hand hygiene and also appropriate disposal of animal products. And then obviously looking at things that you can do with regards to wind and ventilation to really try and stop that, the formation of spread by dust, and also when you're in those sort of tighter areas, improving ventilation to reduce the chance of breathing in the bacteria. So, and covering animal products during transport. Whilst it's highly resistant to a lot of disinfectants, it is killed by bleach, and I think it's more than 63 degrees for half an hour temperature, so there are other measures that will kill the bacteria. So yeah, so that's a little overview on Q fever. Thanks, and any questions?
Can I ask a question more for Simon? How do we go about testing it? Can you just rock up and book in any time to get tested, or do you have clinics, Q fever clinics?
We do Q fever vaccination clinics at least once a year.
Once a year, yep.
And then as part of the screening, they get an appointment a couple of weeks beforehand. We have a blood test and a skin test, and then if you're eligible, then a couple of weeks later you can get your vaccine. But most of the GPs here are pretty aware of Q fever, so if someone comes in with unexplained fevers, feeling unwell, it's prolonged, most of us are pretty good at checking for Q fever.
How common is it?
I probably see at least 1 to 2 cases a year myself. So it's probably, I don't know the prevalence, but
yeah, I mean, it's always hard to know because only about half of people will present with symptoms, and not all of those will seek testing. So I think our data isn't that good. I think the notification rate in Australia is somewhere between 500 to 600 cases per year, but I think that would vastly underestimate the number. And when they kind of they do blood donor surveys, and they do other surveys where they just look at people that have had blood tests and then they check them for Q fever antibodies, and that's where they find about 5% of people have been exposed in Australia, but in some of the high risk areas it goes up to 20%.
Is it a lifetime vaccination, or?
Yeah, so it looks like the vaccine gives you good quality immunity for about 5 years, but there's no recommendation for a repeat vaccination, and I think part of that is that risk of a severe reaction. Is that once you've got immunity, then your immune system may well react to the vaccine. So there's really only that recommendation for the single dose.
How accurate is the test you have beforehand?
Yes.
Whether you've had it or not?
Yeah.
How accurate is that?
Well, unfortunately, none of these tests are perfect, and so the antibody test is good if they're all good tests if they're positive. But you know, the issue is that if the tests are negative, they don't definitively tell you, and which is why you have the combination of the skin test and the blood test, because the blood test in particular, after a few years, you'll often lose evidence of that immunity. And so the skin test is obviously partially as good as the the person that's trained to do it. So when people that work in this area that do a lot of this type of testing, it's fantastic. And you have to be a trained Q fever vaccinator, which you could probably talk about more around that area. But it's good overall, the testing, but it does need to be coupled with that chat about, do you have any risk of having had past Q fever as well. And then there can be some challenges in actually interpreting the tests, but there are lots of great guidelines out there to kind of tell you how to go about kind of working out what they mean, because sometimes the tests come back with these sort of equivocal or unclear results. Do you have any other comments?
Immunisation.
Yeah.
One of the other GPs.
Yeah, and so
20 years or so.
And that's where we sometimes get the odd phone call about what does this test mean. Yeah.
What's the strong reaction if you've had it and then have the vaccine?
It's generally like a local reaction at the site where the vaccination's given, and that's like a really nasty sort of inflammatory response, and people can get like ulcers and it's quite it can cause a lot of pain and yeah, so it's a nasty local reaction.
So it's not life-threatening. It's not like it'll put you down.
I'm sure that there's probably well, yeah, I see where you're going, but I think these sort of nasty inflammatory responses, I suppose, for some people they could be worse than just a local response, but in general that's what it is. But yeah, it's not something that is recommended to be done, unfortunately. Yeah, but for most people it's probably a very nasty reaction that would go away, but it's just not worth that risk. Yeah, and plus you've already got what we would hope would be lifelong immunity anyway, so you don't need the vaccine.
Thanks very much, Emily.
No worries, thanks.